appropriate nursing care plans for children experiencing alterations in urinary elimination. So the big things are, of course, as all kids are smaller, right? But what's interesting is their kidneys are larger when compared to the rest of their body system. So because they're larger, up until they're about 2 years old, they're lower in their abdomen, so they're less protected. So they're more susceptible to kidney injury from accidents. Their urethras for both male and female children are shorter, so that can cause an increased risk for UTIs, or if children get UTIs, an increased risk for further complications like kidney infections, bladder infections. Okay. The other thing is because with females, obviously males and females, but diaper babies, everything gets kind of mixed in there, right? So they're at a higher incidence of UTIs just because of exposure to it. I would say honestly, UTIs are absolutely the most common GU disorder we see in kids, especially in infants. So, and then not usually, but then they can have, like I said, those complications because they're shorter distance to the bladder and the kidneys. The other thing is that they have an increased glomerular filtration rate. So that of course can impact their fluids and medications. So we need to be mindful of that. And then their bladders are small. Obviously, it's going to get bigger with age, but that's why infants will have more frequent diapers, and as they're able to gain that bladder control, as it gets a little bit bigger, they can contain more, is where you get easier time with potty training. Excuse me. When we the two biggest things I think with structural disorders are either hypospadias and epispadias. What's the difference between those two? So it's a congenital defect, right? Where the urethral opening of the penis is not at the tip where we expect. It could be anywhere else, right? So when we're talking about hypospadias, it can be anywhere near the tip all the way down to the base. It can be anywhere in between. So usually for this one, surgical correction is done between 6 and 18 months. Parents, sometimes, anybody who has diaper changed an infant little boy knows that they can go anywhere, right? So you don't know where exactly the urine's going to come out, so you need to be mindful of that and making sure that you have the penis properly positioned to where it's going to go into the diaper. So sometimes they'll even do double diapering. Whereas epispadias, the opening is on the dorsal, the upper side, right? And this one is a little bit more of a challenge, and it usually is a series of repairs. And they'll start them at 6 to 12 months. And this one, unfortunately, also has a higher risk of incontinence, UTIs. So monitoring that urine and monitoring that kidney function.
Why it being on top versus the bottom? Like, why is it worse?
That's a really good question. You would think it would be the other way around, right?
Well, just in general, like it is gonna, you would think it would be the same.
I would think underneath, because then if, you know, a lot of times like little boys, when you change them, it kind of, they have had a bowel movement, it kind of can go everywhere. But I think it has more to do with backflow of urine, because it's got to go up, kind of up. So they don't always void all the way. So urine can backflow up into the bladder or up into the kidneys, is why I think they're more likely to have infections. And then we have a picture. So you can see with hypospadias, it can be kind of anywhere along the penis, where epispadias, it's usually closer, but yeah, I think that's why. I think it's a matter of backflow. That's why I put some in a higher chance. Post. Also epispadias is also commonly associated with bladder exstrophy. So that's where the bladder is not only inside out, but it's also, it comes through the abdominal wall. And that is just something along with like fetal development, why those two go together. So either repair, either one, outside of, like I said, epispadias is gonna be a series of surgeries usual, but you're gonna go along with the same preoperative. They're gonna recommend that the child is not circumcised after birth. They may need to use some of that foreskin during the repair. So they're gonna hold off on that and usually kind of do everything all at once if that's what the parents would like to have done. Post-operatively, so the penis is gonna have like a compression, like a tube dressing around it to hold it in place, and then to also hold, because they'll come out with a Foley catheter. So we wanna hold that catheter in place so that it's not pushing against the surgery site or anything like that. So because it's a type of compression dressing, you need to be really careful that you're checking circulation, that there's not any kind of extra swelling, it's not too tight, it's not doing any kind of damage. And again, just making sure that it's positioned properly. It says pain is typically minimal. I don't have this body part, but I imagine it probably, I don't know why it wouldn't hurt. That sounds incredibly painful to me. But they're gonna be on antibiotics, of course. You're gonna be assessing pain level. And then that double diaper, there's a picture. And you'll teach the parents how to do this until they're totally healed, because now we have a surgical site, right? So we wanna make sure that we're not getting stool in that. So the first diaper, they'll cut an opening in for urine, and then the larger one, it'll be, so like the dressing and everything will stick out through that slit. So, and then you put a larger diaper. So the larger diaper will catch the urine, the smaller diaper will catch the stool. So they're not mixing together. All right, little case study. So what information do we want to gather during our nursing assessment of his genital urinary assessment?
Function,
Yeah?
maybe input and output.
Good. What else?
History of possible infections or other complications related.
Absolutely. Yep. So you're gonna also include, you're gonna palpate for presence or absence of testicles in the scrotal sac, and then assess for any kind of hernias. And then just ask the parents about his usual urine stream. What would you want to include in his post-operative management? Pain, double diapered. What else? Yep. So make sure the urinary drainage tube is in place and the penis is held up, continue to hold upright. Assess urinary drainage from the surgical place stent or from the bag. Excuse me. Change that compression dressing as ordered, especially if it's soil, but that's why we're gonna do the double diapering to try and prevent that. Assess children for pain and administer analgesics and antispasmodics as ordered. Anytime kids have like any kind of urinary or renal, like if they have reimplantation surgery or anything like that, they will usually put them on an antispasm, like for bladder spasms, things like that, because that can be incredibly painful. Provide comfort measures for John and his family. Teach parents post-operative care for home care. Post-operative care for home care. When planning post-operative and discharge teaching, what do we want to include? What kind of things do we want the parents to know about before they go home?
How to properly care and clean the genitalia.
Yeah. Yep. I mean, if there's gonna be any kind of, if he's gonna go home with like a Foley, how that needs to be positioned, how to care for it, how to empty it properly, right? If he's gonna have that compression dressing still, or the penis still, how long it needs to be held upright for. Have parents provide a return demonstration to irrigate the urinary catheter. So a lot of times kids who have like urethral third surgery, there's a lot of bleeding because it's very vascular, right? So you'll have a lot of blood in the drainage bag and blood can clot, right? Or they might pass clots. So you do have to know how to flush that out properly so that if he's gonna go home with that, the parents will need to know what type of activities or restrictions he's gonna have, when you can bathe him and how to bathe him, while the dressing's still in place, and providing care, and of course when to call the physician, right? It doesn't sound like a very fun surgery. Okay, nocturnal enuresis, basically bedwetting, right? So involuntary urination during sleep, it usually is in children between 4 and 6. We kind of get concerned after age 6. Is there something physical going on? Is this behavioral? Are they just a really deep sleeper? It affects 15% of 5-year-olds and drops down to about 5% by age 10. So it can be a couple different things. It can be either a chronic, like they've never been able to stay dry through the night, or it can be a regression where they were previously dry through the night and now they're not. So what are some of the things that you might think about would cause nighttime enuresis?
Drinking a lot of water close to bed.
Mm-hmm. What else?
Neurogenic bladder.
That can, for sure. Stress. That can definitely cause some regression, right? So is it something medically going on with this kiddo? Do they just need to maybe not drink anything after dinner time? Or is there something going on outside that's causing stress, that's causing them to regress? Or are they just really, really heavy sleepers? So there's different things that you can do, like I said, holding off on how late they can drink, or you can get alarms so that it'll go off as soon as it detects any kind of a wetness. That can be helpful. And then just kind of figuring out the basis of it. So this is gonna be a lot of history from the parents, right? So we're gonna wanna know, when were they potty trained daytime, when were they potty trained nighttime, if they were at all. And then if they were previously dry overnight, what's changed? That's the biggest thing. What has changed in this child's life? Is it a new baby? Are mom and dad fighting a lot? Has there been like a death in the family? Are they having trouble at school? Those types of things. So sometimes, depending on the age, you really want to talk to the parents and you want to talk to the kid. And who can be a good help for that? Talking to the child. Therapist, child life, that medical play, if there's something going on that they can't express, right? Can they draw it? Can they act it out for you? So like I said, it does become a concern if it's past the age of 6. It's happening at least twice a week. I mean, anything can happen once or twice, right? But if it's happening frequently, like twice a week, and it's been going on for at least 3 months in a row. So primary enuresis, that's the kid who's never been fully nighttime potty trained, right? They've never been dry all night. And the secondary would be who was previously and now is not. Something's happened to change that. And then just of note, diurnal uresis is daytime loss of urinary control. So treatments, like we said, behavioral interventions, making sure that they do use the restroom right before they go to bed, make sure they're not drinking past dinner time. Alarms can be really helpful. If last resort, if necessary, there are medications that they can take for it. If there's really no other, it's not emotional, it's not a stress thing, it's just, so it's synthetic. Vasopressin, of course, you have to always consider when you're giving kids medications, right? Go over the side effects with the parents and the child. Make sure that they're understanding the medication and the need for compliance, right? So educating them about alarms, about medications, the best long-term solutions. Alarms should still be used even when they're medicated. Usually they'll have better response with combined therapy. Younger kids, you can put them like in a nighttime pull-up or something, but an older kid's not gonna like that, right? I mean, they're not gonna like any of this. Okay. So, remember at the very beginning, we talked about how their kidneys are larger for their size, and they're not really developed until they're about 2 years old. So one of the things that it's not very common, but one of the things that can happen to little ones, it's usually between 2 and 6 year olds, is something called nephrotic syndrome. And basically that glomerular basement, that membrane in their kidneys, it has increased permeability, which allows those larger protein molecules, those larger plasma protein molecules to go through that membrane. So with it, they're obviously losing protein, right? It can have 3 different forms: congenital, idiopathic, or secondary. The biggest things that these kids is most often idiopathic. Secondary can be after a lupus infection or HSP, or it can be seen with patients with diabetes, kids with diabetes. Some of the symptoms that you're gonna see, they're going to have possibly nausea and vomiting, especially if they're having ascites, the swelling of the abdomen. They'll have recent waking because they're gonna have swelling. They're gonna have edema. Usually they'll have periorbital edema first thing in the morning, and as the day progresses to more generalized edema, and it's large amounts of edema throughout their whole body and pitting edema, which is extremely uncommon in children. You're gonna see weakness or fatigue, irritable, and fussiness. So it's leaking those large protein molecules into the bloodstream. So they're gonna have, you do a urinalysis, you're gonna see protein in the urine. The liver is gonna try and compensate, which is gonna cause them to have hyperlipidemia, which is extremely uncommon in children too, right? The kidneys are gonna try to retain sodium and water. And eventually, if unchecked, it can lead to sepsis, peritonitis, thromboembolisms, because there's low intravascular volume, right? All that volume is in their tissues instead. Eventually, it can lead to kidney failure. One of the things that we want to look at is the medical history. This is more common, again, like I said, it's not very common, but it's more commonly seen in children who had intrauterine growth retardation, children under 3, and males. So how do you think we manage this before they get super sick and go into kidney failure, acute kidney failure? What do you think are some of the ways that we...
I had mentioned dialysis, but he said that it's
What are we gonna do before we get to that extreme? What are we gonna try? What are they suffering from? What's going on with these kiddos? They're losing what? They're losing protein. And what else? Yep. So their albumin's low, right? Because it's not in the bloodstream. They have edema, they have low albumin, they're gonna have obviously poor nutrition. We could give them albumin, but they're just gonna keep leaking it out of their kidneys. What do we need to do to help them? Yeah, they're gonna get corticosteroids, and we're gonna diurese them, right? We need to get that fluids out of there. Excuse me. So, like I said, it's gonna start with periorbital edema, and then throughout the day, they'll get more generalized edema. You can see in this picture over here, that baby with pitting edema in their foot, that's extremely, extremely uncommon. They're gonna have a decreased urine output because everything's in their extracellular space, right? The urine they do have is probably gonna be frothy because there's so much protein in it. And then their blood work's gonna show low albumin, hyperlipidemia. So we're gonna diurese these kiddos. Usually like a furosemide is a good one. That's usually well tolerated. But with that, what do we need to be mindful of? Potassium. So we need to be really careful about their potassium. But we're gonna medically manage it with diuretics and corticosteroids. Like I said, they are at higher risk for blood clots, infections, and peritonitis. If they're steroid resistant, it can result in acute renal failure. So, not a fun one. I honestly have not seen this in practice. I don't know that it's something they would necessarily be hospitalized for. They're gonna get steroids. We wanna make sure that we're giving it with food. Watch for infections. Watch for things like Cushing's. We're definitely gonna be monitoring their blood pressure because they're on a diuretic, right? And then we're gonna watch for, it says never discontinue abruptly, monitor blood pressure, renal function, electrolytes, potassium depletion. If they do get albumin, anytime you give albumin, you frequently monitor vital signs while you're giving it. You use a filter and you monitor their fluids. If that is not, if this is not helping, then you would move on to immunosuppressants like a tacrolimus. With that, you're gonna wanna continue to obviously monitor their electrolytes, monitor their blood counts, monitor their vital signs. If they do end up on tacrolimus, you have to give it on an empty stomach, and they have to avoid grapefruit juice and watch for any signs of relapse or infection. Like I said, it's something that's not very common. It's not something I've actually seen in practice, but obviously you can see it's very serious if left untreated. And then the other one is this nephrotic syndrome. So nephrotic syndrome, oh no, it's the same thing, sorry. Monitor their daily weights. Why do we do that? Yeah, so we're monitoring their weight, we're monitoring that edema, check their vital signs, possibly fluid restrictions, depending on the edema and how well it's resolving, infection percentage, we just said this, and then high protein, low sodium diet, right? Because that sodium's just gonna make them retain more fluid. High protein because they're losing so much of it, and then we do want to make sure that we're keeping a really close eye on that potassium, whether they're taking it orally or not. Excuse me. Okay, this is the one I thought was, so the next one is acute post-streptococcal glomerulonephritis. And again, this is one I haven't seen either, but it's an acute kidney inflammation and damage. Usually it can happen for no reason at all, or unknown reasons, but it is an immune response, and it usually is after a group A strep infection. So the immune response damages the glomeruli, causing inflammation, which can actually damage the structure and function, and it usually happens in both kidneys. It's more common, it's not common at all, but more commonly if it's gonna happen, it's seen in children between 5 and 12 years old. And it can be either a group strep, like a respiratory, or it can also be a strep skin infection that can cause this as well. So after they have like the strep throat or the strep skin infection, the body produces antibodies against that antigen, and then those antigens somehow end up deposited in the glomeruli and lead to inflammation. And just like any other weird immune response, they attack things they're not supposed to in your body, right? So things that you will see with a kiddo when they first present with this is they'll have like cola colored urine. They'll have protein in their urine. They'll have frequent urination. They will have edema, high blood pressure, lethargy, and then you'll see that paraorbital or their peripheral edema. Sorry? That's when I said something. So diagnostic, of course, is going to be, we're gonna look at their urine. We're gonna do titers against those levels. And this is self-limiting usually. It'll return to normal within 6 to 8 weeks. But we do to make sure that we're doing supportive care, that we're managing any edema or hypertension they have from it, that we are monitoring their nutrition status, their hydration status. They're not getting dehydrated. Sorry. Did I forget anything on this one? Fever, lethargy, headache, decreased urine output, abdominal pain, vomiting, and anorexia are common symptoms that you'll see with this. So just like with our other one, we're going to use diuretics to get rid of that fluid. We're also going to put them on antihypertensives to control that blood pressure, monitoring their urine, not just their output, but color. Probably going to continue to do testing on it, like UAs, sodium and fluid restrictions during their acute phase, bed rest, and then if it is severe, it may result in dialysis. Like I said, recovery is expected in 6 to 8 weeks, and it's usually self-limiting. Less than 1% will end up with chronic kidney disease from it. Your kidneys luckily have a little bit of resilience to them. So if this is acute and it's treated, it's managed properly, they can bounce back. And then they'll continue to have their blood pressure monitored and be weaned off the medication, the blood pressure medication. Any questions on GU? Like I said, there wasn't a whole lot on this one. I mean, like those two were kind of interesting. It wasn't really straightforward stuff. I feel like kids mostly, if they're gonna have issues, they have like UTIs or like hydronephrosis because it gets into their kidneys because their little ureters are small. All right, do you guys want to take a break before we do emergencies real quick?
Sure.
Okay. Like 10 minutes, and then we'll do emergencies, and then you'll, I think it's like a musculoskeletal case study, I think you said. Just Excuse me. God, I'm so tired of this.
Why do you think he's staring at you all day? That, you see, that's how you put your, you stare at me.